Now we can start the session.
Hello, everyone, and welcome. Hello, everyone, and welcome. I think I got that right. So, uh, let's get started today for our very special webinar on amblyopia, which is a topic that we all care about. And wherever around the world, we'll give you our traditional greeting. Good morning, good afternoon, good evening, and good night, because we are live globally, worldwide, and this is the World Society of Pediatric Ophthalmology and Strabismus New Treatments of Amblyopia webinar. I'm David Granick coming to you from normally California, but I am in Philadelphia today, and we have global speakers for you that we have lined up. Let me introduce my co-moderator, Diane Iso, who's past president of the Brazilian Strabismus Society, obviously in Brazil. She has a PhD, so she's a real doctor, and she's head of the Pediatric Ophthalmology and Strabismus Service at the Hospital de Olhos Paranhá. I'm sure I said that wrong. I apologize, Diane, in Brazil. And she's going to introduce our incredible panel of speakers, which are going to be coming to you globally. Diane?
Thank you, David. It's a great pleasure to be here with all of you. And we have an excellent panel of speakers today, representing different parts of the world, and who will bring us new perspectives and treatments for amblyopia. So please join me in welcoming Dr. Roberta Zaghi. She is assistant physician in the Strabismus Division at University of São Paulo, PhD in neurosciences and vice president of the Brazilian Strabismus Society. Dr. Ben Thompson from Canada. He is director from the School of Optometry and Visual Science in the University of Waterloo, Canada, and CEO from the Center for Eye and Vision in Hong Kong. Mr. Jan Polin, he is an orthoptist at Erasmus University Medical Center of Rotterdam, the Netherlands. Dr. Virender Sachdeva from LVPEI from Vizag, India. Dr. Sarah Malin, consultant ophthalmologist from the United Kingdom, and Dr. Sandra Ganesh, a medical consultant at Aravind Eye Hospital from India too. We are very excited to hear from each of you, and now back to you, David.
Thanks so much. For the audience out there, and I can tell you, I have a little on my phone, I get updated on who's coming on. We already have audience from around the world. Brazil is here, by the way. I'm not surprised, Diane. The United States is represented, Canada, Mexico, Europe, in the Netherlands, in it looks like France, UK, Spain. We have people here from Africa, Italy, Ukraine. Welcome. We have people from the Middle East, from Saudi Arabia. We have Lebanon, Israel, Jordan. Welcome to everyone. We have people from Chile, Argentina. Asia is here as well. It looks like Japan. And I see Hong Kong is here. We have people from China. We have Australia and New Zealand. It looks like the whole world is waking up or going to sleep to our session today. And I hope that everyone will enjoy it. If you have questions, go onto the YouTube page, type in the comments section. They will be sent to us and we will transfer them here. And at the end, we'll tell you about how to get an audience participation certificate when this is all over. I'm going to stop sharing my screen. And we're going to get to the really fun stuff today, the actual talks. So with that, Diane, if you can introduce our first speaker.
So our first speaker is Dr. Roberta Zaghi from my country, from Brazil. And Dr. Roberta is going to talk about medications in the treatment of amblyopia. Welcome, Roberta.
Hello, thank you so much for this invitation. Well, so I'll share my here. Can you see?
Yes.
Yes, so let's begin. Hello, everyone. Thank for the WSPOS for this amazing invitation, and let's talk about the new treatments of amblyopia with medications. I will review where pharmacological strategies stand in 2025. Well, new perspectives of treatment of amblyopia came after many studies over the past decades, showing that amblyopia is not just a monocular disease, but a disorder of visual development with a reorganization of multiple aspects of the visual cortex. This acknowledgement came with the observation that most amblyopia actually begins later in childhood, and it means that there is an early window for normal neural development. But once a risk factor is established, brain plasticity drives synaptic chains that create active suppression and block binocular interaction. So the cortex remains anatomically binocular, but in most cases it functions as if it were monocular. The researchers then proposed the hypothesis that if we could manipulate neuronal interactions through different physical or pharmacological strategies, we might be able to counteract suppression, promote binocular interaction, and achieve a recovery from amblyopia. Pharmacological strategies for amblyopia can be grouped into three main approaches. First, topical ocular action with atropine penalization. Second, central nervous system regulating inhibitory GABAergic system or enhancing neurotransmitters that promote cortical plasticity, such as dopamine, serotonin, and acetylcholine, and intraocular action, inhibiting neural activity at the retina level. So the atropine eye drops penalize the dominant eye by blocking its accommodation and causing visual blur, mainly near, forcing the use of the amblyopic eye and thus stimulating vision recovery. The atropine used for amblyopia is not new. It started with case reports in 50s, then in the 90s it was increasingly used and compared with occlusion. The landmark PEDIG trial in 2002 confirmed atropine was effective as patching for moderate amblyopia. And today, atropine is recognized as validated, evidence-based alternative. After the clinical trial from PEDIG, atropine has been shown to match patching in moderate amblyopia, and weekend dosing can often be as effective as daily. The main side effects are photophobia and near blur, and the choice of atropine depends on age, type, adherence, severity, and family preferences. Other medication is levodopa that combined with carbidopa was studied in the 90s, including by Brazilian groups. And the rationale was that levodopa increases central dopamine levels and could facilitate visual cortical plasticity, potentially extending and reopening the treatment window for amblyopia. However, the large multicenter PEDIG randomized trial later showed only marginal and short-lived benefits compared to placebo, and the gains were not sustained after stopping the medication. Because of this, today levodopa is not recommended by routine clinical use in amblyopia. Beyond levodopa, several medications were tried to boost cortical plasticity. Fluoxetine increases serotonin and could reduce inhibition. It's promising in animals, but modest results in humans and has psychiatric side effects. Citicoline enhances cholinergic and dopaminergic activity, but gains are short-lived. And donazepam may raise cortical acetylcholine, but evidence is scarce and side effects limit his use. So evidence today shows no meaningful clinical effect for routine practice, and we use only protocols or clinical trials. So after decades of research, besides occlusion, atropine remained the only validated evidence-based pharmacological treatment to amblyopia. This couple continuing to be our standard options, either as alternatives or as complementary approaches in amblyopia management, as published by different guidelines. In recent years, new pharmacological approaches have been studied. In adults, vision loss in the fellow eye can sometimes improve the amblyopic eye. Animal models show that total darkness or retinal inactivation with intravitreal tetrodotoxin can reopen plasticity. But clinically, this suggests that suppressing the dominant eye pharmacological might help, but using this medication has still toxicity, risks, and uncertain outcomes. Also, recent research suggests amblyopia may have genetic and neurodevelopment origins, not only abnormal visual experience. This could explain why children with the same ocular findings respond differently to treatment. Understanding these pathways may allow us to design future target therapies. So to close, I would like to invite you all to take part in the annual Amblyopia Awareness and Prevention campaign promoted by CLAD and supported by many countries from Mexico to Latin America in October. And finally, on behalf of Brazilian Strabismus Center and the Brazilian Society of Pediatric Ophthalmology, I would like to thank WSPOS for this invitation to this webinar and for the partnership. We look forward to continuing this collaboration and to welcoming colleagues from all over the world at our upcoming meetings in Brazil. Thank you so much for your attention.
Well, thank you so much, Roberta, for this excellent presentation. And let's now take a moment to address questions from the audience. So if you have questions, please put them in the chat box. And to continue, we are going to move to a short panel discussion together with David.
Yeah, Roberta, that was fabulous. So I'm amazed, right? We were talking about treatments that started in the 1950s, so that's 75 years ago, or treatment, the patch that started several thousand years ago. We're learning so much about amblyopia that it's a brain problem. It may be a retina level problem. It's cortical. There's so much else going on. I know we're going to hear a lot later in this session, but it's amazing, isn't it, how old these treatments are?
Yes, it's because maybe we took too long to understand amblyopia, how it is. And with the new technologies, we could study better the brain. And so make it easier to show what we just managed that amblyopia caused to cortical visual brain. And so in kind of the patching and the atropine can act at the plasticity cortical function by these ways. But now we have some other medications and other forms, physical and pharmacological, to trying to get the visual cortex that it's built in some way and try to make it function another way, even in people that is older than the children that we treat every day.
And Roberta, can you tell us, in your experience, which patients benefit the most from the pharmacological treatments?
Yes, well, everybody knows that the amblyopia by anisometropia is the better one for every treatment that we have, and the pharmacological one is not different. So the atropine goes very well for these patients because we know that the suppression, and once the patient is using your glasses very well, we have everything, and the binocular vision that could be our ally to get better results. And so the patients with hypermetropic anisometropia is the better ones. And so because we have a worst visual acuity on the dominant eye to near, but also to far vision too. And so the penalization is better in these patients. Here in Brazil, we use it not as first choice normally, and we use for the last part of the treatments, and even for that patients that doesn't want to use the patches anymore, and to mild and moderate amblyopia. Here we have a lot of people with dark brown eyes, and so we now are trying to use it 3 times a week and not just twice as the works of Pedig tried. And I have a lot of patients that I use atropine, not as my first choice, but I have wonderful results with it.
So, Roberta, we have people from now Kenya, Honduras, Bermuda, Nepal, Suriname, Argentina, Vietnam, Thailand, Oman, Congo, listening to you, listening to all of us. And a couple of questions have come up. One is, what about the combination of atropine and patching together? How you feel about that? And the other was, we've heard a lot about atropine lately, used for myopia treatment. How does the atropine treatment during amblyopia therapy affect myopia? So 2 questions for you.
Well, the first one was
combination of atropine and patching.
Yes. Here in my office, I don't have much patients that I ever thought about that. But in the hospital and the university, we have a lot of patients that came late to the treatment and have more severe cases of the amblyopia. And so sometimes we tried everything that we have in our hands, and so we try to put them together. And so it's just like a plus treatment, just like when we tried to put the atropine and take off the refraction of that dominant eye. Before to do that, because sometimes the children don't use the glass anymore for anything, and so it's not good for the treatment to the lazy eye. And so I think that's the patch plus the atropine can function better.
And then atropine's impact on myopia when you're treating for amblyopia.
Well, I don't see that in my practice, but I would like to listen to my colleagues too. I don't have a lot of patients with myopia treating in my office. I think that in Brazil we don't have this kind of myopia epidemic because we have a lot of sunshine and a lot of sports going here. And so in my experience, I don't have this data to say it to you.
Have you seen that the atropine treatment for amblyopia affects the refractive error of that patient? That it changes their myopic shift in any way, or that the refraction changes in that eye compared to the other eye even?
No, I've noticed. I not noticed that. I saw a lecture on the other webinar on the webinar 7, and I saw this lecture with great interest. But in my practice, I didn't had this experience yet.
Fabulous. We have more to hear from lots of our panel. Thank you, Roberta. Ben, Roberta said that the brain might be involved in amblyopia. How about we hear a little bit about transcranial treatment for amblyopia? You're up.
Absolutely. Thanks, David. Well, hi, everybody. It's fantastic to be part of today's panel. And again, I'd really like to thank the organizers for inviting me. So as David mentioned, I'll be talking about non-invasive brain stimulation and amblyopia. Before I begin, I do have a few disclosures here. These are patents that are related to some of the work that I'll be describing today. Non-invasive brain stimulation techniques allow us to temporarily modulate the pattern of excitation and inhibition in targeted areas of the human brain. And they may also open windows of enhanced neuroplasticity that we can use for neurorehabilitation. These techniques have been explored extensively in areas such as psychiatry, where some brain stimulation techniques are FDA approved for the treatment of depression, and also in neurology, where they're being explored for rehabilitation from the consequences of stroke. And my group and others around the world have been exploring these techniques as potential interventions for enhancing vision rehabilitation, particularly for older patients and adults with amblyopia. There are two main types of brain stimulation. On the left, you can see transcranial electrical stimulation. This involves 2 or more head-mounted electrodes, and a weak electrical current is passed through those electrodes, and that current has an effect on the underlying brain tissue to either increase or decrease cortical excitability, depending on the type of stimulation that's applied. On the right-hand side is transcranial magnetic stimulation. This uses electromagnetic induction to induce weak electrical currents in targeted areas of the brain. You can target the stimulation with MRI, as you can see in the background here. The magnetic fields are induced in this handheld paddle, and they influence the cortex directly underneath the paddle. Trains of TMS stimulation, or pulses of TMS, can have effects on cortical excitability and potentially neuroplasticity that outlast the duration of the stimulation. So these are the two main techniques that have been explored. So why do we think the brain stimulation would have any effect at all for amblyopia rehabilitation? Well, this is a really nice figure that came out of the LASCA initiative on amblyopia a few years ago, and it maps out all of the different mechanisms that gate or put brakes on neuroplasticity in the mature mammalian visual cortex. And you can see there's a number of these different brakes, but 2 of them are particularly relevant for brain stimulation. One here is inhibition. And brain stimulation, you can see it listed here in the figure, is known to have to reduce the concentration of GABA, which is an inhibitory neurotransmitter in the stimulated area, at least when it's applied to the motor cortex. And also, brain stimulation activates a variety of different neuromodulatory systems that could also open windows of neuroplasticity. So I haven't had time to go into a lot of the mechanisms today, obviously, because it's a brief presentation, but the mechanisms of brain stimulation map really nicely onto the known brakes that exist in the adult visual cortex on neuroplasticity. So this is why brain stimulation is now being explored. One example study that we conducted a few years ago, we asked people to come into the lab on 6 different occasions. They were older patients with amblyopia, and we applied either anodal transcranial direct current stimulation, which increases excitability and reduces GABA concentration, at least when applied to the motor cortex, cathodal stimulation that has the opposite effect, or placebo stimulation. And we did each of these twice, measuring either contrast sensitivity or VEPs to look at perception and also cortical excitability. And here are the results from a single 20-minute stimulation session. This is the change in contrast sensitivity during, after, and 30 minutes after the stimulation. And you can see there's this increase in contrast sensitivity in these older patients with amblyopia, with the amblyopic eye, no effect for the placebo, and a slight reduction for the cathodal stimulation. No consistent effect for the fellow eyes, and our control showed the same effect. Now, these improvements in vision were accompanied by an increase in cortical excitability measured with standard clinical VEPs, with an increase in VEP amplitude for the anodal, no change for the placebo, and a reduction for cathodal. Now, these effects were transient. They lasted only for 24 hours after the stimulation, but they did demonstrate to us that brain stimulation could be worth further exploration. We've also looked at the effects of brain stimulation when combined with other types of intervention. This was a study where we combined brain stimulation with dichoptic therapy that we're going to hear much more about later. It was a crossover design, and the dashed lines here are when the 2 treatments were combined, and the solid lines are when the dichoptic therapy was combined with a placebo stimulation. Each of these points here was 1 week of treatment, and you can see that there was a greater improvement in stereopsis when the 2 treatments were combined than when the dichoptic treatment was given with a placebo stimulation. Now, this effect was only for the binocular outcomes. We didn't see it for acuity, but it did make the point that perhaps brain stimulation could be used as an adjunct for other types of interventions by enhancing neuroplasticity. And this is how it's used in other disciplines, such as neurology, to enhance the effects of physiotherapy. There's been a number of studies looking at brain stimulation now over the years. These are the ones that have used magnetic stimulation. You can see generally positive outcomes here for vision, but a mixture of different types of controls in these studies. TMS is actually quite difficult to have a strong placebo control. Mostly in adults, with 1 study in children. These are the studies for electrical stimulation. You can see here that there are better controls. Most of these are placebo-controlled studies, mostly in adults, small samples, 1 in children here. And the bolded studies are ones where they also used a measure of cortical excitability, either EEG or fMRI, and found effects both on vision and on cortical function. And a number of these studies you can see are combining brain stimulation with perceptual learning, which I know we'll hear much more about later. So this idea of an adjunct intervention. So just to conclude, there's promising initial evidence for the use of brain stimulation in older patients with amblyopia. We're still far from clinical use. We need to have some larger scale RCTs to really explore this effect. And future research might focus on different types of stimulation locations. Currently, it's only been the primary visual cortex, and more advanced research and combined therapeutic approaches. Thank you.
Thank you very much, Ben, for this insightful talk. And now let's take a few minutes for a discussion. And I want to start asking you, Ben, how close are we to bringing transcranial stimulation into routine clinical practice?
I think we're still quite far. It is in routine practice in other disciplines, as I mentioned, in psychiatry, and I think in some areas in neurology as well. I think for us, we just need to have a larger evidence base. So there are some randomized trials that are underway at the moment, not only for amblyopia, but it's being explored for enhancing contrast sensitivity in glaucoma, obviously not affecting the disease in the eye, but changing sensitivity in the brain. Macular degeneration, a similar type of effect. So it's being explored as an adjunct tool for vision rehabilitation. But yeah, we need the RCTs, really, I think, at this stage. But I think hopefully the point I was trying to make in the talk is we're probably there. We've probably got enough evidence now to inform a properly designed RCT, and that will be the next step.
Great.
So Ben, this is mind blowing. Sorry for the pun, but at our institution we have people that are using it right now for depression, and the concern I can imagine in younger kids is what that does to development. But the number of adult amblyopes that are just devastated out there or worried that they're going to lose their good eye at some day, the idea that you can start to stimulate that or reopen plasticity. Is there a role? I'm really curious about the adjuvant role of this from I'm going to go out on a limb, hypnosis to perceptual learning to even things like patching, which, to force people to use it. The studies are going to be pretty intense to try and prove all this and work with it. Diane asked you about how long till this gets into clinic. What are your thoughts about even using this on kids, or how this will eventually be implemented?
Yeah, well, that's a great question. So there are a number of studies that have been that have used brain stimulation with pediatric populations, not so much in vision. Certainly in studies that have looked at autistic spectrum disorder, there's quite a large body of work there as well. I think the attraction of this technique is that it can alter brain function, but in a very targeted way. So if you use a systemic drug, obviously you're affecting the whole body as well as the brain. Whereas here, at least in theory, you can target these very specific regions. And then there's quite a lot of work looking at how brain stimulation of one region can affect cortical networks of activity over time. So there are groups that do this. Our work in my lab is really just focused on adults and older patients, because clearly, as you pointed out, David, that's really a clinical need, that we don't really have any well-accepted treatments there. And we have this neuroplasticity problem. After the critical period, we really are facing a real challenge to look at how the brain can relearn how to use both eyes together. And so I think exploring these types of techniques that are proven in other areas of neuroscience and kind of brain-oriented therapy and applying those to vision is potentially a really fruitful area. But we have to do it thoughtfully.
Ben, I'm going to jump in because you said something that that was my next question. Amblyopia, we can think of as, how do we make vision better in that eye? But you just said, how do we get the brain to use the eyes together better?
Right.
Those are two different issues. Are you seeing the binocular impact as well as the monocular impact? Are we going to see a bunch of people who develop diplopia because we gave them their vision back in one eye?
Yeah, diplopia is an extremely important concern. You're absolutely right. And I guess when I was talking about that, I'm thinking about patients that have reasonable eye alignment, fusion, that we'd be looking at that. But I think we could consider a multi-staged approach to these sort of therapies. And of course, the ultimate therapeutic outcome for somebody with amblyopia would be recovery of stereopsis, and as well as good vision in both eyes. Obviously, that's a difficult goal to achieve, but you could imagine a staged approach where you look at all of the barriers to that recovery of stereopsis sequentially. So it's not like you would go in right off the bat and try to recover that function. You'd have to think about all of the different steps leading up to that. But yeah, I think we should be aiming for that, right? That's the ultimate outcome. So how do we pull together as a community with all of these different types of approaches, make sure we get the right kind of evidence to treating in the right, in the right populations for that end goal? It may be some way off, but I think, as we develop this area, it could be possible to achieve it.
Yeah, and the one sort of throwaway comment that you had about glaucoma, downstream changes in glaucoma look a lot like amblyopia once you get past the optic nerve. So if you can continue to stimulate the rest of the brain, maybe we can recover some of the function from glaucoma. That's incredibly exciting.
We see with our brain in the end. So that's where we have that connection between the eye and the brain, and how that information is being processed is, a legitimate target, I think, for some of these therapeutic interventions. Early days, but exciting times. And I think as we'll hear many other presenters in a similar vein.
I love it. We see with our brain. That's the quote of the day. So we see with our brain. Okay. So Ben, that was awesome. Thank you so much. We're going to go to Virendra next for his presentation on combined therapy. JR is having a little bit of trouble with weather and internet connection. So we'll circle back to him later. Virendra?
Thank you. Thank you, WSPOS, for inviting me for this exciting session on new therapies in amblyopia. I'll begin by bringing back the question that was there from the audience, David, that you said that any experience with combined therapies. So that is what I will be dealing with. And just before that, I would like to disclose that I am principal investigator for Binox Dichoptic Therapy randomized study that's happening at our institute. So we all know that we all start with the amblyopia treatment usually as monotherapy. We treat the underlying cause and we go for specific therapy, most commonly with patching or penalization as the first line treatment. If we look at the reported outcomes, we can see that they are reported good success rates as per the defined outcomes in the studies. However, it is also reported that from the literature that about 70 to 90% of the patients may continue to have visual acuity less than 20/30. So is there something more that we can do for them? The other thing that also does come into question is the compliance, because compliance is most important for any of the therapies to work, and especially in patients who require a prolonged occlusion, more say like that we are giving 6 hours patching for a severe amblyopia. It can be a big challenge. So how about combining different amblyopia therapies? So as we started discussing why, possibly it could give a synergistic effect that could reduce the duration of the prescribed regimen. And there can be a potential to improve the compliance because you require each therapy to be given for a shorter duration of time. So which ones we can combine? If we look at it, there are some studies which have tried combining different methods of penalization, like optical and atropine penalization. There is a study that talks about occlusion and atropine. We'll discuss a bit more about it. How about combining occlusion and pharmacological therapy such as levodopa? There were studies about it, so it did not withstand the test of time. And then occlusion and dichoptic therapy seems exciting. So is it effective? Is there some evidence about it? We will come to it in a little while. But how about we discuss that which cases would be suitable for doing the combined therapy? Could they be de novo or the step-up management? For example, patients who have refractory or residual amblyopia. Well, most of the people do like to start de novo treatment, a first-line treatment as monotherapy, but it could still be considered as in patients who have severe amblyopia. But as a step-up management for refractory and residual amblyopia, this could be one of the modalities. So how do you define refractory and residual amblyopia? Refractory amblyopia can be defined as those patients who do not tend to have an improvement in their best corrected visual acuity less than 1 line. And residual amblyopia can be defined as patients who have an improvement greater than 5 letters or 1 line, but the BCVA still remains less than 20/40, or a 2-line difference does remain between the 2 eyes. Going back to the evidence, so we have some studies which have combined optical and atropine penalization for strabismic and anisometropic amblyopia, and even for residual amblyopia. They have been published in the literature, and there were smaller studies that showed that it is possible. So yes, this method may be applicable and can be tried. Then came the PDIC study, which was looking at randomized trial to evaluate combined patching and atropine for patients who have residual amblyopia. So this was the ATS 11. They took 2 groups of patients. One of these patients were given an intensive treatment with combined occlusion and atropine therapy, and that is weakened atropine and occlusion as per the severity of amblyopia. And group 2 was the weaning. They followed up the patients and recorded their improvement in BCVA and monitored compliance. However, surprisingly, there was not much improvement in the intensive treatment group. Rather, they found that the greater percentage of patients tended to have improvement in 2 lines by the weaning group. So this was quite surprising. But one thing we should remember is that they looked at the 10-week outcomes of the treatment prescribed in this. So in our own experience in our institute, we actually were facing this problem of having patients with refractory and residual amblyopia. And as PDIC further on showed that augmented part-time patching might be useful in these patients, we compared combined occlusion and atropine therapy, which we can also call as COAT, versus the augmented part-time patching. So they were divided into 2 groups, and the methodology was similar. This was more of a protocol-based retrospective study, wherein 2 groups of patients were identified, and we looked at the results. So this is a busy slide, but it tells that the patients were slightly older in the augmented part-time patching group, but they were matched for their gender and duration of follow-ups. If we look at the visual outcomes in these two groups, the line in the blue shows the code therapy or combined occlusion and atropine therapy, and the red line shows augmented part-time patching. So at regular follow-ups at 3 months, 6 months, and 1 year follow-up, we found a much greater improvement in the combined occlusion and atropine therapy group versus augmented part-time patching. This shows the lines of improvement, and we found that in the code group or the combined occlusion and atropine therapy group, there was greater improvement at 3 months, 6 months, and at 1 year in the code group versus the augmented part-time patching group. We also, so this is possibly one take-home message we can take. It can be combined as a method to help the patients who have residual or refractory amblyopia. Coming out to very briefly about combining other methods. So combining occlusion and dichoptic therapy, we know that they have different methods. Dichoptic therapy provides us different clues to different eyes, and you match the contrast so that we can see the single image better. And patching gives the occlusion. So there are various methods which are available for trying the dichoptic therapy. But if we look at the literature, initial studies which came for the dichoptic therapies were using combining it with conventional occlusion. So these showed that it is possibly useful when given in addition to the patching, if we are giving these iPad exercises or dichoptic therapies to the patching. However, more robust studies would be needed in a prospective manner to say that dichoptic therapy and patching can be useful. The advantages would be it can have a lesser emotional stress, greater compliance. We have seen that PDIC has shown that compliance is an issue even with dichoptic therapies. So a more prospective study would help in understanding this better. If we have to choose which patients might be useful, possibly moderate and severe amblyops, and where those who are compliant but can't achieve the necessary hours of occlusion because of their schooling and other issues. And the alignment should be within 6 to 10 prism diopters of orthotropia. And we should have an absence of eccentric fixation. These are my thoughts. I would like to summarize by saying that there are multiple ways by which combined therapies can be done. We can combine occlusion, penalization, and add dichoptic therapies. And usually it is being used for residual or refractory cases, but de novo also it can be tried for severe amblyops. Thank you very much for a patient hearing.
Well, thank you so much, Virender, for sharing your experience and knowledge. And now we have to continue with a short discussion. And what do you see as the future of combining traditional and new treatments, especially about dichoptics? Do you believe that dichoptics therapy can replace patching in some cases, or do you think that it will remain complementary?
So that's a very good question. Possibly at this point of time, dichoptic therapy has shown its potential, but being honestly speaking, possibly a complementary role seems much easier and much more envisageable for me at this point of time. While we are seeing these patients, giving a person 4 hours of patching is very tedious. But if we combine it with 2 hours of patching and you combine it with 40 minutes of dichoptic therapy for a limited period, say like at 12 weeks, there can be greater improvement. And that is what we have seen in limited experience.
Sarah, so we're hearing about combined therapy, and I know you're going to talk to us a little bit about perceptual therapy, but as long as we're talking about combined therapy and sort of to tease everyone about what you're going to talk about in a few minutes, have we been thinking about this all wrong all along and trying to make one eye work and not try and make the 2 eyes work and just covering an eye but not asking it to do anything where kids can zone out and watch television? I mean, should we be combining things?
Yeah,
Sarah?
I think it's interesting, isn't it? Because that's where atropine came along, isn't it? So we went from absolutely occluding to using atropine in one eye to try and enhance that binocularity. And I think Ben hit the nail on the head. We see with our brains, and if we're going to improve cortical visual output, we need to, I think, look at binocularity at the same time. I think we've made big steps with atropine, and I think any new therapies should be binocular. I think if we then look at compliance, and I think if we look at the children that we are all looking after now, never mind the adults that we want to look after, but I think if we look at the children, it's about compliance. And any of the gamification that we're now using, we see from the studies that were done using computer games, I think we now just absolutely need to be embracing that binocularity and trying to reserve, changing completely our mindset and reserving what we thought was gold standard for actually perhaps being something we come back to if the newer treatments haven't started.
Sandra, I wanted to pull you in because you're going to be talking about digital treatment, and we just heard about computers. So what's your feelings about what Sarah and Virender were just talking about with combined therapy?
Yes, yeah, that's a great question. In our experience and in the limited experience that we have, I feel that Dichoptics in its present state works for mild and moderate amblyopias, and isometropic or bilateral ametropic. There are certain situations like strabismic amblyopia or sensory deprivation would still stick to conventional occlusion as of now. So maybe we are looking at a combination, or start with Dichoptics in certain cases and then proceed towards occlusion if it's not working. But in the severe cases, maybe there will be some improvement with time with Dichoptics as well. It's a very evolving field. But as of now, in mild and moderate cases.
Well, thank you. JR, you have been teed up. We're going to hear about Dichoptics, and we've just heard everyone talking about it. They're reflecting back on it. Teach us. We want to hear what you have to update us on.
Thank you so much for inviting me. I will share my screen. I had a little bit of trouble. There's a huge storm going on here in Rotterdam, probably also in Western Europe, and we have a total power blockout. So I'm trying to get everything together. Patch or play? That's the question. And my name is Jan-Olof Polling, and I'm an orthoptist by training. And today I share the results from our trial comparing regular patching with Dichoptic VR Gaming, and ask whether Dichoptics, often called the Holy Grail, is really feasible in everyday practice. So I have no conflict of interest to declare, but I want to thank my colleagues, Sjoukje Loudon here in the middle, Emily Tan, and PhD candidate Evine Katoum, who will defend her thesis on this work next month here in Rotterdam. So we've been patching children for more than 2 centuries on a regular basis. It's been effective, cheap, and globally available, but it's also burdensome, stigmatizing, and compliance is always a struggle, as we found in trials also here in Rotterdam. So when Dichoptics came along, it was presented as the new Holy Grail. It's fun, engaging, and it's a binocular approach, as just had been said, and that could solve everything. But here's the question I want to put to you today. Is it really feasible worldwide? Is it a therapy? If a therapy can't be delivered in an everyday pediatric practice across all kinds of settings, from Rotterdam to rural India, then can we truly call it better than patching? So to test whether Dichoptics really delivers its promise, we designed a RCT directly comparing occlusion with VR gaming, and we included children aged 4 to 12 with a newly diagnosed amblyopia. So after 16th period of refractive adaptation, because if you skip this test, you're measuring the effect of the glasses and not therapy. And our outcome was visual acuity gain in logMAR units. We also monitored compliance objectively with the ODM and explored parents' experiences and preferences. So this study was designed not to just measure outcomes, but also to understand how these therapies work in a daily practice. So the strength of this study lies in the setup. Only children with persistent amblyopia after refractive adaptations were randomized, and glasses had to be worn throughout therapy and testing. And this is crucial. Without that step, you're really measuring the benefit of the spectacles and not the therapy itself. So by ensuring proper correction, we can say with confidence that the visual acuity gains from occlusion or Dichoptics, and not just from finally wearing the right glasses. So if we look at this study flow, this is where reality hits in. From all children initially eligible for participation, only a fraction actually completed the protocol and were randomized. And once in the gaming group, dropout rates were high. Headset was too large, lost interest, didn't understand the game, or simply couldn't make the appointments. So this tells us much about feasibility as it does about efficacy. So this slide is important because it shows the outcome, not just the outcome, but also the process. Only a small proportion of eligible children ending up being randomized. And in the gaming group, dropout was especially high. And that's critical. So if a therapy can be delivered or can be effective on paper, but only half of the children can complete it, it's not feasible in practice. In other words, feasibility and logistics are part of efficacy. So on the left here, you see the visual acuity results. Both occlusion and dichoptic gaming improved significantly over a 24 weeks period. So the median gain of 0.2 logMAR with occlusion and 0.3 logMAR with gaming, but no significant differences. So both therapies improve vision. And on the right here, you see that treatment efficiency, so that is the acuity gain per 100 hours. Gaming looks far more efficient, about 15 times higher at 24 weeks, and even more in the first 6 weeks. But this reflects a small number of the supervised hours, and the effect plateaus after around 15 hours. So yes, gaming appears efficient on paper, but that doesn't make it better in practice. Both therapy improve vision equally. Efficiency numbers alone can be misleading and must be interpreted with caution. So on paper, dichoptics looks efficient, but here's the real world problem: dropouts. Over half of the children in the gaming group failed to complete the treatment, compared to less than 1 in 5 in occlusion group. So the youngest children struggled the most. The headsets were too large, and these were 4-year-olds, right? So difficulty understanding the contrast task is simply losing interest in the game. And the key lesson is here: a therapy is only as effective as it is feasible. Only if most children can actually complete the treatment, then efficiency and efficacy numbers don't mean much in practice. So where does this leave us? Dichoptics is exciting, it's efficient, it's binocular, and it's engaging, but it is not ready yet to replace patching. There are still major barriers: feasibility, cost, logistics, equity of access, and for now, it seems the best suited for older, more motivated children, while patching remains a reliable and universally deliverable option. And that brings us to the broader discussion that I would bring back. Is really add value, and how do we balance innovation with accessibility worldwide? And also, can the VR-based therapies be scaled up in lower research setting? And I really would like to hand that question back to you and to the audience. So I'd like to thank my co-authors and all participating sites who delivered this wonderful study. So thank you.
Thank you, Jan, for this very interesting presentation. We have a question here from the audience. Jan, can dichopic therapy work in a strabismus patient with suppression?
We only included patients with less than 30 prism diopters of strabismus, but it's actually only a small angle strabismus will work. So it's more sufficient to use that in a anisometropic patients.
JR, you said something that made me leap out of my chair. I love this because I'm leaping out of my chair a lot this whole morning for me. Treatment's only as good as the child who will do it. The child will do it. We have. I want to take you back to some of the PDIG trials and the other trials that say patching and atropine are equal. To me, if a family won't use atropine, then patching is better. If they won't patch, then atropine is better.
Exactly.
To call them equal misses the in real life, or IRL, as they say online, aspect of it. And I just want to hear your thoughts about that.
No, you're absolutely right. I mean, it's really it really should match your child, and it's really also be applicable to the child. And now what we see with all the new games coming out, and all the industry saying, oh, it's so nice, we've got all these new games. But children really get bored within a couple of sessions, and they want a new game. And the gaming industry is so fast. So I would really not put that as the holy grail, and look at the child and what their probably their wishes are, to see. So it should be more about the patient who will decide what they like in terms of treatment, and how applicable it is for your local setting.
And Ben, while everyone's talking, I keep thinking we're trying to get to the brain by going through the eyes. You're getting to the brain by going across the skull and directly at the brain. Which is the better pathway to get to the brain?
That's a really great question. I think probably both together might be one of the ways that we could think about this. But also, you know, I was really interested in Jan's presentation. I think that this is a really important point. How do we take our new innovations in neuroscience from animal models? How do they translate into humans? How do we go from the lab into the real world? Really, really critical questions to think about how this could actually impact a patient. And I think for the dichoptic treatment, you know, one of the next innovations might be to see how we can actually integrate that into media that people want to use themselves. Because for patching, obviously, people can do any activity that they want. It's integrated into their life. Could we think of something similar for dichoptic interventions, where people are engaging with media in whatever way they choose to, but we can kind of superimpose that therapeutic effect over the top? And I think it's sort of a bit of a call to action, really, is to think about how we can have these sort of implementations. But to David, to circle back, I think thinking broadly about how we address this question with the brain is probably the approach.
Fabulous. And Roberta, you wrote this fabulous article about the treatment of amblyopia in Brazil. And I'm just wondering, with these tools that are available, Brazil has a varied population, a very diverse population. Do you have to individualize? And how do you write that into an algorithm?
Yeah, that's the difficult part. I'm reading a lot about amblyopia since my thesis of doctorate was about amblyopia a long time ago. And the Dichoptic therapy was the holy grail for me. I thought, oh my God, we now have the thing to treat different kinds of amblyopia with not having problem with adherence. But here in Brazil, we're not having this opportunity to use these new technologies, because it's a huge country. There are some families that has some forms of getting it, and so I can buy it, I can bring it, I can take it at Amazon or maybe AliExpress, because the China has a lot of games and going there. But the most part of our population can get it. And so we remains using the patching and the atropine as our daily basis of treatment. And we're trying always trying to get something new here, to make some clinical trials with our population that is very, very different in our hospitals in different parts of the country, but it's not easy to come.
Thanks. Sarah, perception is reality. We're looking forward to you changing our whole reality with your talk on perception.
Thank you. Let's get this going. Okay. Is that working?
Yes, we can also see that your...
Let me take it this way instead. Here
Yes.
we go. This one, the best. Here we go. Okay, so I think the first thing for me is just to say thank you so much for the invite. And also, it's just inspiring, isn't it, to be in a panel who are still so passionate about bringing vision back, something that we know atropine and patching has worked for so long. And I think it's just a call to arms is a great way to think about it. How are we going to do something? Is there something we can do better? How do we approach that as a team together? And really a privilege to be among you all today. So I have some disclosures. I work as an advisor to the Perceptual Learning platform, Revital Vision. And really, What I want to talk about is what do we do with that amblyop that comes in past the critical period to our offices or to our clinic rooms? You know, it's so disappointing when people are brought in. We have a thing called a Rising 5 screening in the UK, but children are vision's not screened before 5. They reach as almost 7, maybe 8. They've not had any treatment. And it's heartbreaking, isn't it, as clinicians to think, gosh, I'm not sure I've got anything for you that's that good. And we all know that the traditional treatment works to a certain age, and then it's a bit disappointing, isn't it? And as medical practitioners in all of our forms, we don't like disappointing our patients, do we? We like to think, gosh, there must be something more I could do. So the question is there something that we can do that might enhance this cohort of patients? So I'm really going to look at the next 5 minutes at whether or not perceptual learning is something that we should be thinking about in this sphere. So we know that repetitive exposure to a specific stimulus improves neurological function. The question is, can we achieve it with visual function? So we can see from these publications that there's good evidence to support that that is possible. And then came along Dennis Gabor, and he invented the Gabor patch and won the Nobel Prize. And with this simple stimulus, you're able to tailor stimulation of the primary visual cortex. Now, it took many iterations in order to develop what we have, which is a lateral flanking patch to the original target alone patch, which has really shown more enhancement of that stimulation. And the way that this perceptual learning model works is using a concept of visual crowding. Now, this unique utilization allows the program to train the patient under specific visual noise that induces cortical cell excitation. It's all about exciting the neurons so that they upregulate. It's really specific to each patient, so the program learns depending on the responses of the patient. And the crowding refers to the impairment of the target identification. So when the target is surrounded by other stimuli in space, we know that there's an upregulation greater than what we saw with the target alone. And really the beauty of this program is it allows training to happen in what's called the blue area of facilitation. So it chooses the point where the patient specifically is getting the best outcome from the program. So basically the way to think about it is that a Gabor patch with its flankers is a massive hammer, and it's smacking those tiny nails that are the deficient neurons. So that's the way this system works. It really is training that brain. And by doing that, what we find is that you get an improvement not only in the contrast sensitivity, but it's that improvement in contrast sensitivity, the utilization, I like to think, of those lazy neurons, improving your contrast sensitivity, which then causes that increase in visual acuity. But I think impressively also in the improvement of stereo function and binocularity. And we've seen that this is true in amblyopia and nystagmus. This is a summary of 7 trials that are in, but there's more than 30 in the literature if you care to go and look. But 4 of these are RCTs and 3 other studies where occlusion was exhausted or there was non-response. And as you can see, even in these situations, 2 or 3 lines of improvement in visual acuity was gained across the trials. We can also see that that improvement is the same. We spoke earlier about who responds best, but actually we found that this response is the same across different underlying factors, whether it's anisometropic strabismus or so forth, which is reassuring and again unsurprising given that we're training that brain. We've seen improvement in stereo acuity before and after treatment, and we've seen improvement in bilacular function before and after treatment, which is a lovely add-on bonus. The next question I'm sure you're wondering is, does on earth this last? We heard from Ben that and JR that this may be difficult to achieve, but actually we've shown that there has been improvement that lasts for at least 5 years, which at the very least is optimistic and very encouraging. And really that improvement was across those 3 parameters. So not just that the contrast sensitivity remained high, but the visual acuity and the stereopsis as well. So what does your patient do? I really think it's important that we think about whether this is something we can actually ask our patients to do. So it's prescribed by an eye care professional, and the key to this is it's done at home. It's a little bit like the patching. It's 3 times 30 minutes a week, which usually takes patients 2 to 3 months, and they do 30 to 40 sessions until that plateau is reached. They go to do it at home in front of their computer. That individualization or computer-based training is done to make sure they're getting the best out of it. They're seen every month, really just to keep them motivated and show them that improvement. It can be monitored so that they get, just like any app, they get encouragement to keep going, and then they'll reach their plateau, and that's the end. And so the benefit is it's done at home. They don't have any side effects, no patches, no drops. It's fairly low cost, it's efficient, and it perhaps is a new approach. And ultimately, Ben, you'll like this, we're thinking about brain training. So really, in conclusion, this is the perceptual learning platform showed that there was superiority over occlusion therapy in best corrected visual acuity, contrast sensitivity, stereo acuity, and binocular vision in children over the age of 9. And really, I think the recommendation I have in my practice is if I have children who are over the age of 9 for whom I think this is possible, and obviously I'm sure we're about to talk about those children for whom this isn't possible, but there are a cohort where I now really do feel this is something we should think about as an offering to augment what we already have. Thank you.
Thank you, Sarah, for that very engaging talk. And Sarah, could you share with us how well adults adhere to perceptual learning programs, and what differences do you see in the response between adults and these older children?
So the really lovely thing is that actually adults do very well with this. In fact, one of the other definite uses for this is for those of us who still have a cataract practice, with high spec lenses. This is a wonderful way to try and help with neuroadaptation. There's some excellent outcome data in keratoconus, on nystagmus, and other causes of amblyopia. But that's not surprising, given that what we're trying to do is enhance that visual cortex by stimulating it. I think for me, what's interesting is to see the longevity of that. So the adult studies, some of which I showed, but if you chat GPT it, I'm sure you'll see them all, show that there is good improvement in the adult population too, which is important and a group to look at. But I think for me in my practice, it's really that group of children that I seem to find myself so often saying, we're trying to improve your eye as an insurance policy. I remember saying, we'd never know what will happen to the good eye in the future, therefore we want to augment your bad eye. And what I'd really like to do is think about it before I finish, whether or not there's a way of saying, actually, we're going to give you 2 really good working eyes together rather than just a backup eye.
Perfect.
Yeah, that was the spare tire theory, right? That in case your eye blew out. Keep me in mind what JR said, that compliance was difficult with some of these tasks for the younger children. Is that part of the reason why a 7-year-old, a 6-year-old, a 5-year-old is going to get bored or not be able to do the tasks that you're talking about? Is that an issue, do you think? Or why not use this on younger children?
Yeah, for sure. So we know it works on younger children. The problem is that I think getting a younger child to sit for 30 minutes 3 times a week with this particular platform, it doesn't have all the lovely things that JR was showing. It's not ice cream. It's not, it's not Fortnite. It's not Mario. And I think at the moment it needs really motivated people to do it. What you find, like so many treatments in medicine, the motivated tend to do very well, whereas those who are perhaps either have difficulty understanding it or difficulty accessing it don't do so well. And for me, equality of access for care, I think what JR was saying is just so important. We're looking after a global population, and this feels a little bit like it's something that's very much there for those who are able to access it and have people around them to help them motivate. And we all know that's not true of all of our patients. But there are patients that we don't ask. I've sometimes been surprised at just how compliant some of my younger children can be if you give them a chance. I think we sometimes infantilize even younger children and don't give them that opportunity, and yet they'll go home and sit in Minecraft for 5 hours. So I think it's something for us to think. Some of us maybe forget what it is to be a child. I definitely do. And so I think it's a good question to ask. And it's certainly for me something to offer, whereas I fully recognize that it's not for everyone.
I like the way you said that. I think if you motivate a child, you can get a lot. And I tell some parents that, for example, the patch is their ticket to the video game. So, right? I mean, if you don't complete this, you can't go do what you want to do.
Yeah.
Miranda, I'm curious to ask you, when an adult comes in and has amblyopia, do you offer them anything now?
Yes, but to be honest, yes, I explained that there are options. It includes both conventional as well as the dichoptic therapy. I have told them about perceptual learning also, but have not seen them go through the rigor and very poor compliance. That has been the major issue.
Yeah, I think this is so. Last night I was at an event and two people with adults with amblyopia said, "Is there anything yet?" Because they literally live in fear of losing their good eye. Has anybody in the panel done the perceptual learning? Has anyone used it yet? Besides Sarah.
I've done it.
So, but it's available, Sarah. Is that right? I mean,
Yeah. I mean, the ones that I have been helping be involved with is Revital Vision, and obviously that is, you can go onto their website and that's accessible for adults and children. And yes, I think exactly what you've just described, David. That patient who comes to you says, they come to you. Is there anything? What can I do? We are really just a key to some. It's safe. And that's what was so important for me before I started talking about it. It's a very safe treatment to advise people about, and it's like the outcomes are there for you to look at. They are impressive in certain patients.
Yeah, and several years ago, a doctor named Jim Rubin from the United States did a calculation of how much we spend on treatment for various different eye disorders, called using a QALYs. And we spend a fortune on injections in the United States and in other countries for macular degeneration to save a line of vision or letters of vision for an 80-year-old. But here we have an 8-year-old or a 10-year-old or a 12-year-old that you're getting 2-3 lines of vision, and the cost is so little comparatively. And that's all the stuff that we're talking about for children, just vision screening, identifying them. It is so cost effective that we have years of vision, 80 years of vision, perhaps 60 years of vision, 20 years of vision, times multiple lines. It's the most cost effective thing that we do in ophthalmology.
Mm.
So it's an easy call. And with that in mind, we'll segue over to Sandra to talk to us about digital therapies and how else we can try and intervene in amblyopia. Sandra?
Thank you very much. Are you able to see my slides?
Yes.
Yeah. Thank you. So it's my pleasure to be here today evening, and I'll be talking on digital therapeutics. So we've been hearing a lot of talks on this with excellent speak. And so I would start by saying that digital therapeutics works in select situations with a good inclusion criteria. It provides options that are an improvement upon existing therapy modalities, as we know is occlusion and penalization. But advantages here, we are starting with binocular stimulation through binocular balanced viewing systems. And because the duration of therapy is shorter, like an hour a day at maximum, it promotes adherence to therapy. That is appealing visuals involved, including movies or digital content, games, or even the virtual reality. So it's a hit with children and it's child friendly. The range of visual stimuli is over a range of platforms, which can be personal computers or headsets. And this is a list of the common systems in place. Revital Vision system we have heard in detail in last speaker. And Luminopia 1 CureSight and Binox Amblygo working on the dichoptic principles. And these could be used in younger children where we heard that Revital Vision System works well with a minimum age of a little over 9, whereas Luminopia 1 and CureSight being more user-friendly in smaller children, younger children, and it involves using head-mounted displays or viewing digital content with real-time eye tracking in a touchscreen interface. The Binox Amblygo uses anaglyph glasses and is the child has to look at the personal computer or a laptop. Can be tried from the age of 4, but in our experience, we have had successes with children as young as 6 years onwards. And 30 minutes, 60 minutes a day, 5 days a week, and it's purely game-based. So many of these therapies have found regulatory approval in various countries. There has been a lot of interest over these digital therapies over the last couple of years. And the review of evidence with level 1 evidence from the RCTs, level 2 with the systematic reviews and section reviews, and level 3 with several uncontrolled cohort and case control studies. The 2022 Cochrane review says that 16 weeks of binocular vision therapies, digital therapy is comparable with the traditional treatments, but most of these studies have a limited sample size. There is a lack of very long-term outcomes. We do not know the optimal dosage, type, or duration for which these therapies need to be used, and hence there is always a need for additional high-quality RCT with comparison to the standard treatments. And I would like to say that I am an investigator for the Binox RCT with the LV Prasad Group and the Shroff Center at Delhi. So at present can be called as investigational. There is a summary given by the AAO practice guidelines in with regard to dichoptics in amblyopia in 2024, lists the treatment as good and discretionary. They also say that further research is unlikely to change our confidence in the estimate of effect, in the sense that there is an effect, so dichoptics is here to stay. They also state that trade-offs of therapy are less certain, as evidence suggests that desirable and undesirable effects are closely balanced. So there is a lot of promise to this therapy. So I would like to explain a little in detail about the Binox Amblygo platform. We started using Binox Amblygo as a first-line therapy to children and adults with mild to moderate amblyopia around 5 to 6 years ago in our center. So the active graphic components can be seen by the amblyopic eye and are filtered out for the other eye. Both eyes would see some details to encourage fusion. The patient must use both the eyes to play the games. And the children need, or the adults, they need laptop or desktop, the Google Chrome browser and anaglyph glasses, and the ability to set up a Zoom call. In India, at present, the limitation seems to be the availability of digital devices because it's a huge country and everybody does not have access to these devices. The visual functions at distance and near, heterophoria, tropia measurements, the Wirtz 4 dot for the binocular vision, the near stereopsis, all can be done online. And these are the list of the games that can be played online, and it's very user-friendly. They are not addictive, and even small children are able to play these games. So what we do in our center is we follow a hybrid approach in which we instruct the child. We do a demo session to see the ability of them to play or use the interface for starting the therapy. And you can see that there are various games which are used for various therapy modalities. The Super Squad helps in anti-suppression, Super B for stereopsis, the Vergence games which improves, like there are games for improving Vergence as well. So it is used to treat anti-suppression, anti-crowding, contrast, visual acuity, form perception, speed recognition, apart from just traditional acuity enhancement. So this is how the therapy looks like. It has around 5 to 10 minutes of 2 or 3 different games, along with fusional divergence and convergence. So after initial assessment, there is a demo session explaining the therapy activities. Every 10 sessions, an online assessment is done. You can do remote monitoring, and this is a great advantage because you can actually see how well the child is performing the therapy. This is a case example of a child using this Amblyopia platform for the treatment of anisomyopia with a contact lens in place. And you can see the improvement in vision from 0.6 to 0.3 logmar over the duration of 3 months with improvement in binocular vision and stereopsis. So this is a study that we published with a cohort of 74 patients. This is a study which is a real world study. So we could actually select the patients who are able to do the therapy. And you can see that we have enrolled patients across all forms of amblyopia, including anisometropic, ametropic, deprivation, and strabismic, though predominantly they belong to anisometropia and bilateral ametropia. The inclusion criteria is mild to moderate with foveal fixation. I would like to say here that foveal fixation is mandatory. If they are eccentric fixators, we exclude them. And if there is tropia, there are patients whom we have operated and aligned them prior to starting the therapy or giving small prisms. So we found at least 3 logmar line improvement in anisoamblyopia over 60 to 90 sessions. Similarly, with ametropic, there were 5 cases with pseudophakia and partial cataracts were operated and then found good improvement in visual acuity and contrast sensitivity post the therapy. Strabismic amblyopia, 50% of them improved with the strict inclusion criteria in place. And from here, you can see the improvement in fusion and stereopsis as well over the course of the therapy. Couple of them achieved near normal stereopsis as well. And I would also like to say that there were patients who underwent patching and then they had failed patching probably because of poor compliance, and after dichoptic therapy continued to improve. So this is something very promising in the sense that patching is not easy. There is a lot of psychosocial impact, and if they are not compliant, then you can always try dichoptics even after failed patching. And we have found that the therapy, the improvement in visual acuity stays even after follow-up, a minimum follow-up period of 3 months to a longest follow-up that we have of 2 years. There is a new program called Squinties, which has been introduced by Binox from this March, and it is called Squinties. So in patients who have intermittent exotropia and post-strabismus surgery, we have tried with good improvement. And because this uses some games to improve the convergence, divergence, and vergence parameters as well. So this is a patient who was operated for pseudophakia at the age of 5, underwent strabismus surgery later on for a huge exotropia, and who has residual exotropia with poor fusional vergence and stereopsis. And following therapy, you can see the improvement in vision from 0.2 to 0.0 logmar, improvement in the near point of convergence, and positive fusion and vergence facility, and NCS score also. So I feel that dichoptics is here to stay, and there we may be looking at improvements coming up in the future. Thank you.
Thank you, Sandra, for this wonderful presentation. And Sandra, what do you think are the main barriers to making digital therapies more accessible or worldwide?
I would say with reference to the countries such as India, where cost and accessibility to devices such as a personal computer or laptop, that is what is the problem that we face in our clinic. There are a lot of patients that whom we like to enroll, but since they do not have access to devices, they have to stick to the conventional therapies. We do encourage them, if they are from nearby, to come to our center to use the devices for a couple of hours, like an hour a day, but still it's difficult for patients who stay far away from our hospital.
Thank you.
Sarah, is there a way to take this kind of digital therapy and tune it with perceptual learning so that underneath or as part of it, you're really hitting the same places that the Gabor patch does, or that there's a way to use the information and combine it to something that might be more engaging, like a video game or other games?
Yeah, for sure. And actually, if we think about EDT, that's exactly what we do, isn't it? Where you have something to engage the patient, and the contrast sensitivity, of course, is really helpful. But if you then are able to work out exactly how many times you need to stimulate and how much interest you can have, I think the combination would be certainly something we should be thinking about, as long as it didn't extend the time.
Exciting. JR, you used Logmar when you did the study that you reported. We're still talking about black letters on a white background. Now, vision is so much more than that, yet we decide whether or not something works by black letters on a white background. Sandra mentioned that they looked at more things, speed of recognition and other things. What should we be looking at in amblyopia? Are we missing out? Are we stopping treatment too soon? Well, should we be using a whole other scale?
Well, we could indeed. Contrast sensitivity is one to look at, and we did that. There was also not much difference between those as well. So also between patching and the dichoptics. So no, there's not your answer, is there? Yeah, we done that Logmar historically, and it's also our a gold standard as it is right now. And I would not step away with that because it's what we're using every day in clinic, and until there's anything better than that, it comes down to more the experimental setup. So it's very hard for clinicians then to compare how to relate to that. So I think the Logmar will stay around for a while.
David, can I make a comment and
Of course.
make a?
This is a free for all now, where it's all in.
Okay, so I have the opportunity to use Binox here in Brazil because it's just one of the platforms that we can achieve here. And I have two contrasting situations. I had a highly engaged 13 years old boy that looked for treatment with game because they had a late diagnosis of amblyopia that went very well. The other cases that I indicated that didn't make it because the cost, because it's still very high for Brazil. And I had one child with 8 years old with ADHD that couldn't make it anyway because they can't stand seated doing, and the games are not for fun, they are for treatment. So they are very boring in such a way. And so I think that commitment, it's poor because of that. And I have a question for our colleagues that has much more experience with digital therapy. The use of the time screen, it's a concern between pediatricians and we in ophthalmology pediatric basis and for some families. And so do you have any concern about prescribing these treatments with saying to the children using 1 hour a day of screen time and the possibility to, for example, increase the risk of myopia?
Sandra, what do you think?
I can answer that a little bit. So with the Revital Vision one, it's 30 minutes 3 times a week. And if you look at the amblyopia triggers, the myopia triggers, that's okay. Interestingly, just on a question about the myopia, with the use of 1% atropine as an occlusion therapy to limit, if you're using it for the PEDIG required time, so if you use it for the full 6 months, in my experience is you will find a reduction in the progression of the amblyopia in the treated eye, particularly if you start treating them when they are pre-myopic. So we're all desperate now to get the pre-myopics because that's when they get the best effects. You may well find in your anisometropic myopes, if you are amblyopic, anisometropic and myopic, and you give them 1% atropine, you'll find that you'll stabilize them for 6 months. The problem is they're all too little. So when you stop the atropine, it just starts again unless you use something else. But anyway, that was just an experience thing on that. But no, at 30 minutes 3 times a week, I don't worry about myopia, but I'm far more worried about the British population who for 30 minutes 3 times a week is a fraction of what they're already doing.
Yeah. Sandra, what do you think about telling parents to have their child sit in front of a screen?
Actually, I would say this is useful for improving their vision, but even in the schools, children use a lot of digital devices nowadays. Many schools are using, iPads for education. So they are going to be using that lot more hours than what we are recommending. So I think the risk is always there, but we need to educate the parents and the family that they need to strictly adhere to the time that we are recommending it for, and have rules in place at home.
So let's talk about cost for a moment. Patch, relatively cheap. Atropine is often covered, but we have several different countries represented here. I don't know if it's covered in all of them. And then we have these digital therapies as well. Ben had to run. So the transcranial, God knows what the cost will be for that. Well, how does cost play into this in the various different countries?
Well, that's a good point, David. And I would like also to highlight not only the cost from the devices and insurance, but also the cost. I mean, I have 15 minutes to explain an amblyopic kid that it has amblyopia, and to explain the parents how to patch. If I have to do that with a digital device, and I see them in 3 months or 4 months, but if I had to do more follow-ups, I mean, this would cost me a lot of money to or staff to facilitate all this. So I think there are much more costs involved doing it, for instance, in dichoptics or any other binocular exercise, or where you need devices because you need to train children much more and to facilitate that. So that's also a cost. I'm not really eager, and that's why I don't have any experience, because I just don't have the time nor the staff to facilitate this all.
So JR, is that where telehealth and at-home visual acuity testing would make a difference?
Absolutely, I think that would definitely help, and also we're not there yet with these measures as well, because there's not a gold standard for that as well. So, but it definitely might be the future. I'm also a little bit worried that we're just don't have enough numbers for that.
I think, David, interestingly, sorry, I just very quickly, if you have a country where there's a national health service like the UK, if there could be a standardized protocol that was then put into schools using telemedicine, where that kind of financial input was made by a country looking after an equal of access, where we already have a screening test, where that then led to absolute clear treatments that were encouraged by schools, then we're really able to facilitate something. I think individualization of expensive treatment just means that those who can afford it and have access will get better treatment, or perhaps different treatments, and those who don't can't. And we're fed up with that now, I think, as doctors. So I think unless there's a national adaptation, I think it's difficult.
Yeah, and yet compared to all the costs that we have, as I said earlier, these are all cheap. And screening in a school is cheap. We do it in San Diego. We've screened 400,000 kids, and it's inexpensive. It can be done much more cost effectively than, for example, some of the treatments we have for macular degeneration. Diane?
Yeah, I agree with you. And being practical now and talking about real life, which of these approaches do you believe that will become part of standard care in the next 5 years, for example? I know we have a lot of, we've seen we have a lot of promising options, but do you believe that in the next 5 years, patching and atropine will remain being the standard care for amblyopia in most of the countries?
Everyone and anyone.
Oh yes, I truly believe patching and atropine will stay around, because the other the devices are too complicated. I mean, you need maintenance on the devices, and also we did a qualitative study on what parents like about patching. What the mothers say is that they put a patch on and send a child off to school. Whereas if you have to devise, you have to supervise them at least 3 times a week to do 30 minutes of playing. And parents don't like to supervise their kid while doing that. So I think that's a problem as well.
We have some
I think for the sub-8 population, I think it'll be very difficult in 5 years to change what we've got, which is cheap, efficacious, and well tolerated. I think for the over 8 population in the next 5 years, I think it will change.
It's so exciting to have some of these options. And we got one question that I want to make sure we got several questions that we've addressed from the audience, but one that just came up is, How come video game makers are so good at making addictive games that kids will play for hours and hours at a time, yet for amblyopia, we can't find something like that? Sandra,
well,
are we going to have an addictive amblyopia game?
But what we need is one of the gaming companies to decide they're going to do this. So a bit like Deepthink giving its money in order to be able to do big genetic research, or like we need one of the big gaming companies to say, I'm going to give this back to the world. I'm going to create this game. I'm going to make my gamers make a game that will work. Because we know how many people have got PlayStation and Xbox, you'd make it non-station dependent, so it'd be cross-platform. Boy, that would be interesting, wouldn't it? Could you imagine Sony, PlayStation, Xbox all going together on this? But that's the sort of global thing that would suddenly push the needle. And as you said, it's not expensive. They have the ability to do it. You guys in the room have already shown them we can tell them what to do, but it's whether or not that kind of philanthropic notion is there among the gaming people.
I think that the games are so boring. The children would rather wear the patching than the games. They just ask for the patching.
Might be if it a different way. It is possibly not the game itself, but also the fact that they are required to see the portion with the amblyopic eye. So in a dichoptic therapy, the portion that has to be seen through the amblyopic eye is hindering it. The child is not able to enjoy it to the same level. Whereas in immunopia study, they found that compliance was much better as compared to the other dichoptic therapies. So looking into all that aspects might be something that we are missing. So while we have the cost as one issue, we do face a different challenge in India. We face patients coming and saying that patching is much more difficult to do in the school hours. We have to give them in the off school hours. And parents are keen to do the amblyopia therapy by dichoptic therapy, but the compliance goes down later on. So maybe it is the requirement to see binocularly with the two eyes together and using the eye with the amblyopia having to be used is the problem.
Well, sadly, we have to wrap up as our time is up, but this has really been just incredible and so exciting to me to be a part of, as Sarah mentioned, just such an enthusiastic group. Amblyopia, it's so vital and so important. And we've just sort of been set in our ways in terms of our treatments to start thinking about new ways, or as Bennett said, the brain is what sees. To get to the brain is just an incredible moment. For those of us, those people who are online, please send an email to admin at WSPOS to get a attendance participation certificate if you need that. And if there are any questions that you have, please email them as well. We can ask the panel. We often will put together an answer sheet and post that at wspos.org as well. There are more webinars coming. The next one is procedural comfort in pediatric ophthalmology. With kids, we keep talking about compliance, and these become really important. To get cooperation matters. So we'll have a whole webinar just on that coming up. And if you didn't know, the next World Congress of Pediatric Ophthalmology and Strabismus will be in Cancun, Mexico. Yes, that's what the water looks like, on May 13th to 15th, 2027. So we invite everyone to start circling those dates on their calendar and prepare to join us in combination with SOPLA for the World Congress, the 6th World Congress. If you've been to one, you know how amazing it is to connect with your colleagues around the world who are doing new and innovative things, who are thinking differently, who may be facing the same problems you are and may have solutions that you haven't thought of, and also just to make new friends. So circle that date, May 13th to 15th, 2027. Also, there's a survey going on that we invite your participation on pediatric IOL implantation. And there's a survey. You'll be entered to win a prize, including, ready, free registration to Mexico, the World Congress 6. So please take the survey. It's on the WSPOS website, and we really would love to have you join us there. For anyone who hasn't seen it yet, the Myopia Consensus Statement 2025 is online right now at WSPOS.org. It is a compendium of what we know to date. It's updated from 2023 because, gosh, in 2 years, the amount of information we have has just exploded. The same is being done for amblyopia, and we'll have that soon. But it's just an ongoing update. It's for the clinician. It also, we have information for the parent as well. It's in various different languages. And we have a podcast that you can listen to give you that same information. So hopefully that'll be fabulous. Here are the QR codes if you want a direct link that you can go right to make it easy for everyone. I'll leave that up there for a second so you can take a picture of it. But these will take you directly to the consensus statement, including emergent therapies for myopia. Finally, membership at WSPOS is free. It has always been free, and it always will be free. So please think about joining WSPOS if you haven't. It gives you access and updates and early updates. Stay tuned for lots of new things that are coming. We have exciting new announcements that will be coming up very soon. I'm going to tease that. But there's a whole library of educational videos, surgical videos. And again, membership is free. So please join us. I run a listserv. It has been going on since the early 1990s, over 30 years. Makes me old, I guess, for pediatric ophthalmology and strabismus. We have 1,800 doctors and specialists in the field, online, discussing cases, sharing thoughts all day, every day. It's exciting. It's invigorating. And just write me. Let me know who you are and that I can confirm that you belong in the group, because we carefully make sure that everyone who's in the group is really should be there. So there's no advertising. It's just us talking. Please just email directly and I'll make sure that happens. A big thank you to our sponsors, Binox and Vital Vision, and as always, to NTOD for really making all these webinars possible. Without them, none of this would be possible. And we appreciate the effort, time, money, investment, and the guts to take on new treatments that both Binox and Vital Vision are doing. Without that, we don't get these new treatments. Finally, and perhaps most importantly, I want to thank our panel for their collegiality, their enthusiasm, their energy in what they do, how they take care of patients every day. I mean, truly, it's very hard to give a 6-minute talk. And we know that took a lot of effort to do. And on behalf of all the patients around the world, who all of you have helped by helping all of us learn more today, I get the beauty and benefit of saying thank you. And Diane, I want to thank you for your collegiality and the joy of sharing with you to be able to have you put together this session and run it with me from halfway around the world. Very deeply appreciated for your efforts as well. So with that, I will stop sharing. Thank you to all. And it's time to either go on with your day or go to sleep, wherever you happen to may live. Thank you once again to our panel, and we'll look forward to seeing you next time right here at the WSPOS website and on YouTube. Thanks to all again. Thank you all. We're going to log off now because we're still being recorded and people can still see us. So thank you so much for everything.
Thank you.